Welcome to Thumb CMC Osteoarthritis, Precise Examination and Non-Surgical Treatment. We want to alter the course of the disease. It's logical then that there would be referred pain in the area of the dorsal sensory branch of the radial nerve, that the balance of motion already shows a less than ideal posture of the thumb. And there is a 7-degree greater range in abduction, in full extension, than in this posture. I've gotten a hold of the entire thumb, I'm stabilizing here, and I'm moving in a radial direction. And I'm stabilizing it with my left thumb, which is the thumb we're testing. But each patient must be individually evaluated and treated. It would be far better if the arch could be recreated and the CMC joint can come into more extension. Stability and mobility, those are absolutely opposite terms. But they had isolated CMC osteoarthritis, and they were all evaluated. There are at least 20% of therapists in the UK who do not use exercise. If increased range of motion results in pain, the motion you gained isn't really very helpful. A lot of the thumb muscles fire in synchrony, and it's almost impossible to know if or when you're isolating. We don't want to reinforce the MP hyperflexion. The way we move the thumb with CMC arthritis is very different from the way we move the normal thumb. But your focus in this part of the rehab is to avoid that old pattern. From my view, the question is not what is the best orthosis for osteoarthritis. The question is, what is the best orthosis for this patient? They need to restrict motion at the IP joint for either hyperflexion or hyperextension. Use an orthosis appropriately to maintain the CMC joint in mid-range during loading, if that's the joint that needs to be maintained. And the orthosis, in my opinion, should allow the thenar muscles to contract, not limit other joints, and you need to figure out, is the CMC the joint we need, not the other joint.